Developmental dysplasia of the hip DDH is a musculoskeletal disease. Infants or early childhood. Look at this picture, shows that normal hip joint and dysplasia of the hip. Look at this, head of the femur is displaced from acetabulum cavity. In ultrasound findings in infants, CT findings, and X-ray, normal hip and displaced hip. Look at this. Detail going on. Introduction. Developmental dysplasia of the hip DDH refers to spectrum of hip joint abnormalities that range from mild instability to complete dislocation. It is a condition that arises during fetal development, infancy, or early childhood, and if untreated can lead to lifelong complications. Etymology. The term developmental dysplasia of the hip is derived from three key components. Developmental, indicating its occurrence during growth. Dysplasia, from the Greek word dys, bad or abnormal, and plasia, formation, meaning abnormal development, and hip refers to the hip joint. Together, it described as conditions involving abnormal formation or alignment of hip joint during development. A definition: DDH is a condition where the acetabulum, hip socket, and the femoral head, thigh bone, are improperly aligned, causing instability or dislocation. This severity can range from mild subluxation, partial dislocation, to complete dislocation. Types: subluxation, partial dislocation of the femoral head within the socket. 2. Dislocation, complete loss of contact between the femoral head and acetabulum. 3. Acetabular dysplasia shows underdeveloped hip socket without displacement. 4. Tretologic hip dysplasia, hip abnormalities present at birth, often associated with other syndromes or conditions. Causes: 1. Genetic factors, family history of DDH. 2. Mechanical factors, intestine positioning, example breech presentation, tight uterine environment. 3. Hormonal factors. Maternal hormones can lead to ligament laxity in the fetus. 4. Environmental factors. Swaddling practices that place the hip in extension and abduction. Risk factors. 1. Female gender due to maternal estrogen and laxin effects. 2. Firstborn child. 3. Breech presentation during pregnancy. 4. Oligo hydromenose. Low amniotic fluid levels. 5. Family history of DDH. 6. Postnatal factors such as improper swaddling. Complications. Osteoarthritis in early adulthood. 2. Chronic hip pain. 3. Lymph length disturbance. 4. Reduced range of motion in the hip. 5. Gout abnormalities such as limping or waddling. Pathophysiology. The hip joint is a ball and socket structure. In DDH, improper development of the acetabulum and femoral head leads to instability. Lack of contact between these structures can impede normal growth and development, causing further deformity and dysfunction. Here is step-by-step pathophysiology of DDH. 1. Intrauterine factors. 2. Ligament laxity. 3. Abnormal joint contact. 4. Acetabulum dysplasia. 5. Progressive instability. 6. Secondary changes. 7. Mechanical impairment. 8. Chronic abnormal stresses. Without intervention, abnormal stress on the hip joint can lead to progressive deformity. Over time, this may cause early onset osteoarthritis and other long-term complications. The underlying process of DDH starts with a combination of mechanical, hormonal and genetic factors leads to instability of the hip joint. This results in inadequate contact between the femoral head and the acetabulum. Preventing normal development and the ossification of the hip joint. Without treatment, the condition worsens and can lead to long-term joint dysfunction. Signs and symptoms. 1. Asymptometry of thigh or gluteal folds. 2. Limited range of motion in the affected hip. 3. Shortening of the affected leg. 4. Positive Oriolini and Barlow tests in neonates. 5. Hip clicking or popping sounds. 6. Limping or waddling gait in older children. Diagnosis. On clinical examination, A. Ortolani and Barlow Manivirus. B. Galicia Singh. Apparent leg length disturbance. To imaging. A. Ultrasound, ideal for infants under 6 months. B. X-ray, used for older infants and children to assess bone structure. 3. Screening, universal or targeted screening depending on risk factors. Nursing diagnosis. 1. Impaired physical mobility related to joint instability. 2. Risk for impaired skin integrity related to immobilization devices. 3. Risk for delayed growth and development. 4. Acute pain related to surgical interventions. 5. Anxiety related to diagnosis and treatment process. Management. Medical management. 1. Non-surgical Paulic harness for infants under 6 months. 2. Hip abduction braces. 2. Surgical, A. Closed reduction and casting. B. Open reduction for severe cases. C. Osteotomies to reshape the hip joint. Nursing management. 1. Educating patients on proper harness or brace application and care. 2. Monitoring for complications like skin breakdown or improper alignment. 3. Pain management post surgery. 4. Supporting developmental milestones within treatment constraints. 5. Providing emotional support to families. Treatment options. 1. Conservative, A. Pelvic harness. B. Physical therapy. 2. Surgical, closed or open reduction. B. Pelvic femoral osteotomies. C. Post surgical spica cost application. Psychosocial medicine. 1. Counseling to addresses parental anxiety and guilt. 2. Support groups for families dealing with DDH. 3. Teaching coping strategies for parents and children. 4. Providing age appropriate activities to promote social engagement despite mobility restrictions. 5. Advocacy for accessible resources and community programs. Prevention. 1. Avoid tight swaddling that restrict hip movement. 2. Encourage proper hip positioning in carriers and seats. 3. Routine screening for early detection, especially in high risk infants. In conclusion, developmental dysplasia of the hip is a manageable condition when diagnosed early with proper medical and nursing interventions. Children can achieve normal hip function and avoid long-term complications. Early detection and a multidisciplinary approach are key to successful outcomes. Thank you. Have a nice day.